Good afternoon, everyone. My name is Ellen Barra, and I'm a member of our Provider Outreach and Education team for WPS Government Health Administrators. On the call with me today is my friend and colleague, Jennifer Boniface, who is going to be taking care of our chat functions. So she'll be watching for any questions or information you're placing into the chat. And then in addition to that, if we have any information we need to provide to you, that will also be contained in the chat. The first thing that we have is our disclaimer. This education that we're going to provide today is really a tool for you to use in order to bill appropriately for these services. Now, this particular service we're talking about today, Social Determinants of Health, or SDOH assessment, is a pretty new service. It just started January 1st of 2024. So we do expect Medicare, CMS, to continue to discuss this topic, to continue to place information both in MLNs, in the internet-only manuals, in their education as we go forward with this. So whatever CMS is publishing, that's going to be the final information. We will provide responses to your questions based on the specific question you've asked, but of course the Medicare rules again will determine final coverage. And then CMS does prohibit recording of the presentation for profit-making purposes. So if you're doing screenshots, if you're recording this in some way, we would ask that you stop. We are recording this, and barring any technical difficulties, this will be available both on our website, under the Training Center, under Encores, probably within 2 weeks of this presentation. And then it will also be available on our YouTube channel within that same time frame. So the next slide that we have up for you is just the acronyms that we're going to be using during this presentation today. And you'll notice that bottom one, the SDOH, based on CMS, this is social determinants of health. I know that there have been other words that have been used there. That's the terminology that CMS is using at this time. So what are some of the things we're going to talk about today? Well, we're going to talk about the difference between a screening service, which is not separately payable, and this assessment, which is separately payable by Medicare. We're going to talk about frequency limitations for this, billing this in addition to other services, and then the documentation that you'll need to support this service. A screening service is really determining if an SDOH applies. A screening may result in referrals or references to additional community resources. And since CMS has been placing, since the public health emergency, such an emphasis on health equity and making sure that underserved populations, underserved types of beneficiaries, etc., are really receiving the medical care that they need, your offices have started doing this screening to determine from the patient whether there are any problems or things that you need to address. The assessment is where the information that you have received is making a difference in the medical decision and in the care that your physician or practitioner is providing to that patient. They could make changes to the plan of care based on the results of the assessment. It could influence the plan of care and the decisions made. And so your documentation for this is going to go back to that proof of thought of your practitioner. What are they considering in looking at this information for that patient's plan of care? Administering a screening can be done by ancillary staff. Administering the assessment can be done by your ancillary staff, but using that assessment, which is the billable service, that is a practitioner service only. And we'll kind of talk about the documentation as we go through. The procedure code is listed for you here, the G0136. You'll notice that this is 5 to 10 minutes, not more often than every 6 months. Now, if you happen to go over the 15 minutes that is listed here, there is no additional service or units of service that you would use. It is just this one procedure code. So this is the time of the practitioner to determine the ways in which those findings on the screening service that you've done may influence that plan of care. Again, this goes back to the thought processes and the expertise of the practitioner involved in that service. Medicare will allow this risk assessment no more than once every 6 months, and this is per practitioner, per patient. So a patient could have more than one of these within a 6-month time frame, but a practitioner can only bill once per the 6-month time frame. There's examples within the MLN that talk about how this can work. Your assessment can be both administered and used during the same encounter, or it could be where either your clinical staff or a patient-completed form can be done prior to your actual encounter with the patient. And then this would allow you to have time to incorporate that into your practitioner's medical plan for the patient. You want to make sure that when you're billing for this, you're billing for this on the date this assessment is provided, which is generally going to be the date that it's completed, that you have implemented this information within your medical plan itself. So if your ancillary staff or your patient complete this prior to, you still bill on the same date as your encounter. So some of the examples where you would incorporate this, the patient could be calling for an appointment with your office, and they really stress with you that they only have certain times available because of transportation issues. This could be public transportation. You know, the bus can only drop them off at your office after 4 o'clock. They can't get there any earlier than that. Or friends or family that may be bringing them, they don't get off work until 4. Can you provide an appointment after that so they have time to get there? Another example listed is calling for a refill of some type of refrigerated medication, maybe such as insulin, because their electricity has been terminated. So then your practitioner is going to be documenting, this is the information that I have, and here is what I'm going to do with that information. The patient tells me they lost their electricity is now back on. I can reorder the same medication. Or if I believe that this could be an ongoing problem, then as part of your documentation, your physician would address what he or she is going to do instead. Patient can't keep the refrigerated medication, so therefore I'm going to do, and then whatever it is that provider's going to do. When you're looking at the information to gather on this, you do need to use a standardized evidence-based risk assessment tool. And that has to, at a minimum, gather information on housing insecurity, food insecurity, transportation needs, utility difficulties, etc. Issues that could be prevalent within your patient population or within the location of where you're located, where your patients are located at, you could certainly add additional questions to this. You want to use tools that have those questions relating to your population, including the culturally needed, which could be additional languages. It could also deal with certain religious or cultural restrictions to certain types of treatment. What we have up on your screen here are just the front page of 3 different standardized evidence-based tools that are listed within the CMS publication, the Medicare Learning Network Matters document. And the link to that document is in your resources section. The prepare document, you can see there in the middle of your screen, also comes in several different languages. And then, like I said, the links to these are within the MLN, where we have a link to that within your resource section. You can provide this service with your evaluation and management services. You'll notice there that the lowest level established patient procedure code, the 99211, this SDOH assessment would not apply there because that's a clinical staff service, not your practitioner service. It also applies to certain behavioral health office visits, and you can see the procedure codes that are listed there for you. And then you want to let your patient know that cost sharing can also apply. Now, when we're talking about E&M, we have listed there for you the 99211, which is an office visit procedure code. This service is not restricted to only office visits, though. If you're doing discharge management, as an example, then this service could certainly apply to that, where you're making those discharge management decisions and you're using the information from that assessment to help you make the best choices for your patient. In addition to that, when you're doing transitional care management, that face-to-face service, this SDOH assessment can also apply to that one. It's a best practice for you to let your patient know about the additional cost sharing because they are responsible for deductible and coinsurance. But you can also frame that conversation to let them know the value that they are receiving from this service. What this allows you to do is it really allows you to more tailor your medical decision making for the patient's unique circumstances. And it takes into account, again, any issues or concerns that the patient may have based on the social determinants of health. You can also provide this with an annual wellness visit, and the 2 procedure codes are listed there for you. You would bill it again on the same day and on the same claim, and you can append modifier 33. When you append modifier 33, it means that cost sharing does not apply as long as we pay for the annual wellness visit. Now, a couple of things to kind of let you know on that one, because while this information is what was published within the final rule, this information has not yet been implemented from instructions from CMS as of today. We dealt with and talked to our systems area yesterday to make sure that we knew how these procedure codes were going to process until CMS finalizes the instructions on modifier 33 for this service when billed on the same day as the annual wellness visit. So for right now, what is happening is that when this procedure code comes in with the annual wellness visit, if you append modifier 33, we're going to deny. CMS has not instructed the contractors yet to allow this modifier with that procedure code. They are working on those instructions right now. I don't anticipate that until probably the fall of this year. The other thing is, if you submit this and you don't append modifier 33, then we will apply the deductible and the coinsurance to this service. So what do we do on this one? Well, based on what we know, since CMS instructions have not been issued yet, you have a couple of choices. You can append modifier 33 if you choose to, and then when you receive that denial, you'll hang on to that claim until the final instructions are put out, and then you'll simply resubmit that claim. It will deny, it will actually split your claim, and it will deny as an unprocessable claim as of this point. Again, we're anticipating the instructions in the fall. At that time, you can simply resubmit those as new claims. We will have the history claim already on file, and then we will be able to process that without deductible and coinsurance applying. You can also choose to go ahead and submit that procedure code now without modifier 33, knowing that deductible and coinsurance will apply. If you choose to do that, then when CMS's instructions are final, then you can request a reopening of that claim, which means that you can go into our portal, our transactional portal on the website. You can do a clerical error reopening, add the modifier 33, and then we'll be able to make up that difference for any deductible or coinsurance that was applied. What you want to think about on that one, though, is that you'll have to make refunds back to your patients or to their supplemental insurance companies if they've already paid for that cost sharing that would apply to that. You could also request an appeal, but really a clerical error reopening is your best bet. So whether you decide to hold these until later this year, whether you decide to submit them now with modifier 33 and receive the unprocessable denial, or you decide to submit them without modifier 33 and deductible and coinsurance would apply, that's really your business decision. Medicare is fine with whichever way that you want to go on that. And then when the final instructions are done, then you can, based on whichever way you chose, then you can take care of the actions in order to receive that payment. CMS has not indicated that the Welcome to Medicare or the initial preventive physical exam is an appropriate companion code for this service. They are indicating that annual wellness visit. So Medicare allows this at both a facility and a non-facility. So the use of this procedure code can be used in facility settings. And again, this is not an incident to service, it's your practitioner service. It's your practitioner's time and work and their expertise, their thought processes on determining what they're going to do based on these identified risks for the patient. The same situation applies, the same rules apply to all locations. Practitioner is evaluating that SDOH assessment and using that in making the medical decision making for the patient. Some things to think about. Is the patient in a long-term nursing home? This probably would not be a situation where you would use the SDOH because of where that patient is located at the time of the service. If the patient is in a hospital stay, you probably would not use this procedure code for your subsequent hospital visit codes. You would, however, as I mentioned earlier, be able to use this with your discharge management procedure code. And then that same thing would hold true if you're discharging a patient from a skilled nursing facility or from a nursing home. So the expectation then is that the patient would have an identified unmet social determinants of health needs that will continue, and then you would be following up on that information either through your transitional care management service or your E&M visit. So you can also see here that this service can be done through telehealth. As long as your companion code can be provided through telehealth and you're performing this assessment, then you can bill this using the 02 or the 10 place of service code. You'll just use the same place of service code that you use for your companion code. So what documentation do we need to have then for this? Well, again, this goes back to the practitioner's proof of thought. So the documentation really will show how that practitioner is using that information and what updates or changes they have made and considered for their plan of care. The follow-up is going to be critical. Now, think about something for a minute. They're as good as your practitioners are, as good as your support staff are, your community resources, you're not necessarily going to be able to solve every issue that your patient may be having under this SDOH assessment, but you do need to be following up on that. Are they taking advantage of any community resources that you have suggested for them? Have they made any changes that will change that assessment? So this could be changes to your plan. It could be referrals that you make to other community organizations to assist the patient. It could be future appointments that are set up to accommodate transportation needs or something like that. But that's what you want to have within your documentation. How has your practitioner used this information, to determine the patient's plan of care? A diagnosis code must accompany the service, just like anything else. You can use one of those Z diagnosis codes if you choose to. It's not required, however. You can also use the diagnosis that reflects the reason for the encounter. The time spent that you're doing this assessment can be part of the services for community health integration or the principal illness navigation when you're not billing separately. And so what I mean by that is both of those two procedure codes have time involved in that. So if you're doing both a principal illness navigation, for an example, or the community health integration, the time that your practitioner is spending doing this assessment and applying that to the care plan, they can incorporate that time into these other two services if they choose. But if you choose to do that, then you would not bill for this procedure code separately. The next information you see here, for the rural health clinics and federally qualified health centers, this can be provided and it can be billed on the claim. However, because it's an incident to service, it is payable under the encounter code. So that would be your annual wellness visit, your evaluation and management, etc. And no cost sharing would apply for RHCs or FQHCs. This would be part of the cost report that you would be submitting into Medicare. So the next thing that we have are your resources. So we have provided you information there from the Medicare Managed Care Manual, which has information on this assessment. We have provided you with a link to the Health Equity Services, MLN. And then Jennifer is also going to place within our chat another MLN, and it is Medicare and Mental Health Services. That also provides some additional information about the SDOH assessment. That one had not been published at the time that we completed this presentation. You have, oh, no, it's actually on there. I'm sorry, we got that one in here. There's an MLN on the Medicare wellness visits that you can take a look at that has information on this. And then the physician's fee schedule final rule summary is also available there for you. And then that last one is the Medicare and mental health coverage. I didn't think that was published before we did this. And then there's additional resources there for you, both for rural health clinics and for the federally qualified health centers. So next we're going to take questions, and I do have a couple of pre-submitted questions that we'll go through, and then we'll ask Jennifer to open that up. One of the pre-submitted questions is, well, what do you do if your practitioner has not documented this? Well, if your practitioner hasn't documented it, then it wasn't done. And of course, if it wasn't done, then you can't bill Medicare for it. So that's education that you want to provide to your practitioners for them to indicate within the medical record how they used that information. And it could be as small as I'm choosing this drug over that drug because this drug has a smaller copay. And I know my patient, based on the assessment, does not have the resources to pay for the other drug. It can be as small as that. It could be bigger. I'm ordering home health care because the patient does not have electricity. They're not going to be able to get electricity. And I'm going to work with a nurse from that home health agency in order to come and give that insulin injection every day. So it's a wide range of things that can be accomplished through this. But yes, your physicians will need to document how they used the information within their medical plan. Another pre-submitted question is, what should we as coders and auditors be looking for? Well, it's just that documentation that we talked about. How are they using that in developing the care plan for that patient? And then the last pre-submitted question I have is, how does this relate to the community health integration services? And when an SDOH issue is identified, the assessment will show how to incorporate that into the care plan. The provider's office may then determine to provide the community health integration services to address that unmet social determinant of health. So again, the services can kind of go together. You can bill for them separately. You can also incorporate the time that you're spending on this SDOH assessment into your community health integration service if you choose to. So that's the information that I have for you today. We'll go ahead and open it up for questions. Jennifer?
Hi, Ellen. Right now there's no questions in the chat.
Okay.
Ellen, we just did get a question.
Okay.
SDOH cannot be performed without companion codes. Is this correct?
This is correct. You want to remember that this procedure code that we're talking about is the assessment by your practitioner during an encounter. It's not a screening or referral to another agency or something along those lines. It is what your practitioner is doing for that patient. So you would need to have a companion code on that. Anything else?
Yes, we did get a few in. The next question, does the provider have to document a known or suspected SDOH that interferes with the provider's diagnosis or treatment of the patient before they're able to perform the SDOH assessment?
Yes. So that's what this is all about, because you really want to separate the screening, which your offices are doing with your patients to identify these needs, and the assessment of that need and how that affects the care plan. So for an example, if I make an appointment with my doctor, they may be asking me some of these questions. Well, if I don't identify that I have any of these needs, then when I see the doctor, they're not going to include this assessment because there's no identified needs that will affect their care plan. If on the same, process, you make an appointment with the doctor and there is a need that is identified, that information then is shared with your practitioner, and your practitioner has to incorporate that within their care plan. And again, it could be minor, I'm choosing this drug over that drug because of cost. It could be something much more major than that. But that's what your documentation will be. Next question.
Okay, give me a, let's see. And anxiety and depression considered SDOH.
The information within, let me get back to that slide here. Hang on a second. I get back to my paper. The information within the assessment is going to be asking about things such as housing insecurity, food insecurity, transportation needs, utility difficulties, etc. Take a look at those standardized evidence-based tools to see what other things they could include in that. I don't think that it includes necessarily includes the mental health services, but take a look at the documents themselves. And if they do, if they're asking questions about that, then you can certainly, when you're using that information to determine the plan of care, then yes, this procedure code could be billable. Have to be documented though. Next question.
Okay, the next one is from, let's see, it says, we get denials when Z codes for the SDOH diagnoses are used as primary diagnoses. Is Medicare allowed them to be primary?
No. What you want to use as your primary diagnosis code is your medical reason for the encounter. Patient is here today for a follow-up of their diabetes or their hypertension or whatever the reason for them being there. The Z codes can be used as additional information to support the other things that are going on with that patient at the time of that service. So no, don't use it as a primary code. Next question.
Okay, you shared the option to submit, gain denial, and resubmit in the fall. With the historical claim, is there any concern that the claim filed in the fall will reflect as a duplicate?
No. And that's a very good question. It won't reflect as well, let me say this. When you resubmit that, if that's your choice in the fall, don't resubmit the service that has already been paid, because that will deny as a duplicate. What you'll do though is you'll resubmit just this procedure code along with that modifier 33. When we're processing that claim, we will be able to see the fact that the encounter code has already been paid, and then we'll be able to continue processing this one for payment. Next question.
Okay, so RHCs will not receive additional reimbursement for G0136.
That is correct. What CMS says is that you can bill for those. And you can bill for that on the same code or same claim rather as your encounter code, but cost sharing will not apply to that. And then that would be part of your cost reporting, through that normal AI all-inclusive rate or prospective payment system rate.
Okay, our next question has two questions in it. Would you repeat the ancillary staff was able to perform? Oh, sorry. Can you repeat what the ancillary staff was able to perform, and was the time only time by the provider, correct?
That is correct. The ancillary staff can gather the information. So on one of our slides, I showed you the picture of just 3 examples of the standardized evidence-based tools. So you could have your ancillary staff do an interview per se with that patient to gather this information. That's your ancillary staff. That's part of the screening. When you get, then you'll provide that information during the encounter, either, handing them the paper, reminding them that it's within the medical record, however you work that within your office. And then this procedure code reflects the work that your physician or practitioner did to address any of the needs that have been identified through that tool. Next question.
Okay. Is it a requirement that the provider document how the SDOH is interfering with the diagnosis or treatment?
They have to document how they have used this information. So for an example, if you have a patient who identifies that they have food insecurity, let's just say for an example, and your physician's documentation shows nothing to address that food insecurity and what they plan on how they plan on addressing that, then you don't have the service. If your physician's documentation identifies the patient has food insecurity, and here's what I'm going to do, here's the plan of care that incorporates that, then yes, you could build this procedure code. Next question.
Okay. Is there a Z code to use when assessment is performed, but the patient doesn't have an applicable SDOH?
I have absolutely no idea. I'm not familiar with all of the ICD-10Z codes. Next question.
Okay. As far as who can bill the service, since a variety of provider types could perform an AWV, for example, if they are credentialed to perform the companion service, are they able to perform the SDOH assessment?
If the let me get to that slide. Hang on one second here. When you're talking about the AWV, again, that can be done by a group of healthcare professionals, but then you would not build this procedure code. It's if the AWV is being provided by your practitioner and they are using this SDOH assessment in their plan of care, then you would append this. Excuse me, if your AWV is being provided by the healthcare professionals under supervision of the billing provider, this procedure code would not be billed. It is a practitioner only service.
Next question, they're asking if FQHC won't get reimbursed for using this code.
They will not. What CMS has stated so far is that you can submit it. There is no cost sharing for the patient for this, and you would simply include it on your claim if you chose to, and then it is part of your cost report. The 2 MLN documents that we have on your resource page for RHCs and the FQHCs, I believe that is addressed in there.
And that's the last question in the chat.
Okay. Thank you so much for those questions.
Oh, we just got another question.
Okay.
Okay, does the assessment need to be within the provider's note or within the medical record sufficient?
As far as Medicare is concerned, you simply need to be able to produce it. So if Medicare, contacts you, either WPS or another medical contractor asks you for this information, you just need to be able to produce it. How you store that within your medical records, that's up to you.
And we have another question. Can you please explain a cost share report with the FQHC billing portion?
I can give you some basic information on that. Rural health clinics and federally qualified health centers are not paid under the fee-for-service payment system. So for an example, Medicare says we're going to pay, $70 for an office visit. Rural health clinics are paid under what's called an all-inclusive rate. And so that rate is determined based on previous years' services that RHC has paid or has made to the beneficiaries. A rural health clinic is paid based on what's called the prospective payment system, and it is based on what's called the diagnosis related groups. So depending on the diagnosis, that could increase or decrease reimbursement back to an FQHC. At the end of every year, these two entities, along with others, but these two, submit what's called a cost report to the Medicare auditors, and they go through all the information that's in there to determine whether or not Medicare's all-inclusive rate or the prospective payment system rate is correct. And then that affects future payments going forward. That's the information I have on what is a cost report.
And it looks like that's the last chat question, unless another one pops up. Oh, there is another one. So, and the same person asked, so essentially just ups the PPS rate?
Well, now I can't say that it will increase the prospective payment system rate. There's a whole lot of math that goes into that, and that's over my head. CMS determines those amounts.
Okay, now it looks like that's the last chat question.
Okay.
Now.
So on behalf of Jennifer and myself, we want to thank you very much for your attendance today, for the questions that you have provided to us. We do encourage you to take the survey. It provides us with a lot of great feedback, and we pay very close attention to the information you provide back to us. As we stated earlier, this presentation, barring any technical difficulties with the recording, will be available on our website under the Training Center page under Encores, probably within the next 2 weeks. It will also be available on our YouTube channel, again, within the next 2 weeks. So thank you very much for your attendance today, and you can now disconnect. Have a great day.